All right, thanks for that morning burst of energy, Colleen. Good morning, everyone. Thank you so much for joining us today. We're getting ready to begin our first presentation of the day. My name is Audrey Coachman, and I am the Program Manager for the Central North Florida chapter of the Alzheimer's Association. The presentation we are about to view is Disorders of Skilled Movements Associated with Dementia. Our speaker for this presentation is Dr. Kenneth Howman. Dr. Howman joins us from the University of Florida's Department of Neurology, Department of Neurology, and from the Geriatric Research, Education, and Clinical Center from the Malcolm Random Veterans Affairs, sorry, this is a mouthful, Veterans Affairs Medical Center in Gainesville. He received his MD degree from the University of Virginia in 1963. He joined the faculty at the University of Florida College of Medicine in 1970. From 1998 to September 2017, he was the James E. Rooks Jr. Distinguished Professor, and he is currently a Distinguished Professor Emeritus at the University of Florida. He joined the staff at the Veterans Affairs Medical Center in 1977 and continues to be a staff neurologist. Between 1996 and 2009, he was the Chief Neurology Service at the University of Gainesville, VA. As Director of the Behavior Neurology and Neuropsychology program, he helped train more than 70 postdoctoral fellows, and the majority of who now own or have hold academic positions, and several are now leaders. His research has been supported by the NIH and the VA for more than 40 years. He is the author and editor of 20 books, more than 100 chapters, and more than 670 journal publications, and more than 60,000 citations. Wow. He is the past president and received a Distinguished Career Award from the International Neuropsychology Society. He is an honorary member of the American Neurological Association. And most recently, in 2019, he was awarded the Distinguished Lifetime Contribution of Neuropsychology, awarded by the National Academy of Neuropsychology. Remarkable achievements. It's my honor to introduce to you today, Dr. Howman.
Can people hear and see me? Hello? Can people hear and see me?
Yes, sir.
Okay, good. Okay, well, thank you for that wonderful introduction. It's nice seeing you. To give a talk right after a beautiful woman who did such a wonderful job, I'm not sure that's something that I want to follow, but today I'm going to talk about a loss of skilled movements. And it turns out that usually there's very little interest in this. When I first came down to the University of Florida, I've been here several years, somebody said, well, Dr. Howman's going to give a talk about apraxia. And two physicians in the first row said, hey, did you ever had a patient complain about apraxia? The other one said, hell no, nah. He said, okay, let's get the hell out of here and get a cup of coffee. And it turns out that there has generally been very, very little interest in disorders of skilled movement, especially of the upper extremity. But it turns out that these disorders are some of the most disabling things that can occur to humans. And one of the sad things are almost no physicians, including neurologists, for the most part, test for these disorders. So I'm going to talk a little bit about apraxia today because it turns out that people with cognitive disorders and dementia very, very commonly have these disorders. And I think it'd be important for the family, first of all, to recognize these because recognition can help in many ways help these individuals because without recognition, very often people remain disability and it decreases their lifestyle and also can hurt them. So originally, when people spoke about apraxia, it was a definition of what it's not. So it was defined as a loss of the ability to perform purposeful skilled movements when this deficit could not be explained by things like motor weakness or sensory deficits or movement disorders like tremors or ataxia or career-form movements and many, many other types of disorder, as well as not being able to understand what needs to be done. In general, there are four major types of apraxic disorders of the upper limb. And I'm going to go ahead and just go over these and explain what these disorders are. I'm a neurologist, so you're going to have to suffer because I'm going to mention at times about the brain and what it does. So the first one I'm going to talk about, we gave the name, or Liebman in 1920 gave the name limb kinetic apraxia. What is it? It's a loss of finger deafness. Now the humans are amazing, okay, that we have such wonderful finger deafness. I always love to tell the story of when I was walking down the hallways with my mentor, Norm Geschwin. He saw a neurosurgeon walking, and the neurosurgeon had these magnifying glasses on his head. And Norman said to him, "What are those things on your head?" And he said, those are magnifying glasses. And Dr. Geschwin said, why are you wearing those? And he said, so we can see what we're doing. He said, that's interesting. We walked away, and Geschwin said to me, "Isn't it interesting that humans need magnifying glasses to be able to get feedback from their hands and fingers because their movements can be so precise that you can't see it without magnification." And we all know this. So how do we test for this? Well, neurologists have this real expensive test, and you can do this with family members, okay? Is we give people a nickel and we tell them to rapidly rotate it between their fingers. People who have limb apraxia very often will drop it or very slowly and have difficulty rotating that disorder. Well, it turns out that many things we do, like buttoning our shirts, like sewing, and many, many other activities like this, require precise, independent, but coordinated finger movements. And many patients, especially with diseases like Parkinson's disease, who are demented, or even Parkinson's without dementia. Many patients with strokes, many patients with other degenerative diseases, and there's many of them, very, very often will show disturbances of this. And it turns out what we've learned over years is that if you're right-handed, it appears that the left hemisphere, controls this. For many years, we thought, well, why are you right-handed? And most people in early neurology said, the reason we're right-handed is because our left hemisphere mediates language. And that was shown all the way back in the 1800s. Okay, if you're right-handed, more than 90% of people have language in the left hemisphere. But when they looked at people who were left-handed, they found that 70% of them also had left hemisphere dominance for language. And handedness has more to do with the skills of the hand than with language, except perhaps for writing. And therefore, things like the ability to perform these precise but independent coordinated finger movements, okay, actually is probably makes us right-handed. And it turns out that if we have an injury to our left hemisphere, especially in the more front parts, in the motor cortex and the premotor cortex, we lost our skills of both hands. Now, as I mentioned, this is a terribly disabling disorder. And people have to be aware of it because, as I said, there's so many things from sewing to buttoning shirts that requires this. Now, I wish I could tell you a quick way of curing this. Of course, as a neurologist, the first thing you always want to do is about seeing if you can treat your underlying disease. If you can't do that, although there have been no studies of rehabilitation of this, okay, in general, we know that when you practice something, it improves your skill. That's true of almost anything. And so what I often tell my patients who have this disorder, I say there is several things, okay, that may help. One of the things I do and suggest is to put dimes all over a table and ask the patient or family member to pick them up. Now, there's two ways of picking up a dime off a table: a pinch grasp like this, or taking it and sliding it off the table and then grabbing it. And patients with limb kinetic apraxia very often initially will slide them off because they can't do this. But what I do is very, very often start with bigger objects, okay? Things like bottle caps or even bigger objects than that, and then eventually move down to smaller and smaller things. So from a quarter to a nickel to a penny to a dime, until they're able to go ahead and use that pinch of grass to pick it up. And I already showed you about the coin rotation. And similarly, before you get down to a dime, you may want to start with something larger, like a quarter, and have this practice this and see if this can help them improve their ability to perform these type of movements. Now, the next form of apraxia that I'm going to talk about is called idiomotor apraxia. Now, in general, very, very often, when I see patients in the clinic and I ask them questions and I want to examine them for idiomotor apraxia, I say to them, could you show me how you use a pair of scissors? And very often what patients will do is use their fingers. Now, this is an emblem of scissors. It's not how you use it. And even normals will, when I ask them, do it. But then I say to them, look, don't use the blades as your fingers, okay? Make believe you're really holding a pair of scissors. And many patients with disorder we're talking about will continue doing this. There'll be other patients who make postural errors, okay? And that's the first type of errors you'll see. So what they'll do is they'll actually move their hands around and make all these postures rather than the incorrect posture for using scissors. So you can see postural errors, okay? The next type of error we often see are people using the wrong joint. So we'll say to people, okay, show me how you would use a hammer to pound a nail in a board that's on a table. And I'm not sure if everybody can see my arm, but a lot of people will just go like this. what they're doing is you're like using their fist as the edge of the hammer, and they're just moving either their elbow or their shoulder and elbow. To pound a nail into a piece of board on a table, what you have to do is make wrist extension. You can use your arm also if it's a heavy nail, but you still have to make this wrist extension. So another error people make, okay, is very, very often not using the correct joint. And the third type of error people make is not coordinating joints. So if I say to somebody, show me how you would slice a piece of bread from a loaf of bread, your shoulder comes forward, and at the same time your shoulder comes forward, you extend or straighten out at your elbow, and you go back and forth, and then slowly lower this down at the shoulder. So you have to coordinate both the shoulder movement and the elbow movement. If you just use your elbow, then you make chopping movements. And many, many people with this disorder will just make chopping movements. The last thing is, when you make a skilled movement, you have to correctly direct it, okay, at what the target is. So if I say use a screwdriver to put a screw in the wall, you want to keep the screwdriver, okay, in the screw. You want to keep it stable. And many patients with this form of apraxia, okay, will move their hands in all different ways. Okay. Now it turns out, unfortunately, even though I would like to be able to tell you, oh, you take this pill and it'll cure it, okay? Again, there hasn't been a lot of studies done on it. But what is important, however, is to realize when patients have this is very commonly seen with Alzheimer's disease. It's actually very, very often one of the first symptoms of Alzheimer's disease. And although people usually think of Alzheimer's disease as primarily a memory loss, I think when it was originally described, Alzheimer's gave it three major signs. One was memory loss, one was word finding difficulty, and the third thing was apraxia. So even though I can't tell you about a great cure of this, again, practicing and correcting these movements certainly can hurt. And so you can practice certain movements that your significant other or the person you're taking care of does, and see if you explain these things and say to them, oh, look, if you're going to hammer a nail, do this, okay? And help them out and practice with them and do it. But what is also important is to know about it so that people who have this disorder, okay, can perform their activities of daily living and can be helped in case they can't. And when there's instrumental activities, which means working with things, if they can't do it, to be coached and then actually helped with this disorder. The next one I'm going to talk about is something called ideational apraxia. And again, this was also described by Hugo Lichtman. And what he noticed is that very often when people, especially again with strokes and dementias, especially those that involve the frontal lobes, but again, this can be Alzheimer's or the multiple types of frontal lobe dementia or vascular dementia, or even with head trauma. And even, by the way, a lot of these things are also seen with children with learning disabilities. But anyway, what he noted is almost all things that we do, we have to perform in sequence. And so what happens with what's called ideational apraxia is people can't correctly sequence a series of movements. So for example, in these patients, if I took out two pieces of slices of bread and I brought out cheese and ham and mustard and a knife. And I'd said to them, could you please make me a sandwich? What they may do is take one piece of the slice of bread and cut it in half. Okay? Then put the ham on top of the bread, and then put the other piece of bread on, and then cut the other slice, and then have to take it off and put the mustard on, and so forth. So their problem is performing sequences correct. And in almost all activities that we perform, okay, in the house or in our job, they're very, very often the sequence that you have to follow. This is probably one of the easiest things to help, because if these patients and these people and family members can still read, okay, what you can do, and they're performing skill acts and they're messing the sequence up, you can just put a piece of paper in front of them and say, okay, take the bread out, put the mustard on the bread, put the ham and cheese on one piece of bread, put the other piece of bread on top, and now slice it in half. So that's one of the ways that it can be done by them. Now, the last one I'm going to talk about very briefly is something that we call conceptual apraxia. And that's an interesting story. What happened was we had a grant funded by the National Institutes of Health to do some of the research that I also mentioned about the nature of the errors that patients with apraxia perform. And we had a wonderful graduate student, okay, who was helping us out. And what she was doing was actually taking video pictures while patients with strokes performed actions, so we can analyze the nature of errors. So when I went over, I was walking past her as she was at the VA, and I was walking past her, and there was a man in the bathroom, and this man in the bathroom had toothpaste in one hand and a toothbrush in the other hand, and he started brushing his teeth with the toothpaste. I went over and said, Cindy, you know what this man has? And she says, yes, Dr. Hellman, I don't know what he has. I've never seen anything like this before. I said, he has something called an agnosia, a visual agnosia. He cannot visually recognize what the objects are, but he also may have a tactile agnosia because he's also holding them. And she says, no, Dr. Hellman, that's not his problem. And I said, watch, he won't be able to name these things. So I hold up the toothpaste and I said, what is this? He says, toothpaste. I said, what? And what's this? I hold up the toothbrush. He said, toothbrush. So I said, that is so bizarre. So we had a wonderful nurse at the VA. And I asked her, you know, when this man eats in the evening, when you serve him dinner, does he have any problem eating? And she says, no. So that evening I stayed around and watched how he ate. But what she did, she came by, she went ahead and poured the sugar in his iced tea and stirred it. And then she cut all the pieces of meat and vegetables, removed all utensils and just left them with the fork, and he just did fine. And I said, yeah, that's very interesting. She doesn't realize it, but she's taking care of him. So next day, what I did is I just put some other things down, other tools down with his actual utensils. And the first thing he did was open the sugar, pour it in his iced tea, and they had a nice iced tea teaspoon, but he didn't use that. He picked up the knife, put it in his tea, and then he rotated and stirred it that way. And then the first thing he did, he has creamed corn. I put a toothbrush down there. He picks up the toothbrush and starts trying to eat the creamed corn with the toothbrush. Finally, he was suffering so much, I took it all away, cut up his food, and just left him with a fork. But then I said to me and people I work with, Leslie Gonzalez-Rorting, you know, it appears that this man has a loss of his mechanical knowledge, a loss of his mechanical knowledge. So after this, we developed a whole bunch of tests. First of all, to see if people with dementia and strokes, whether or not they often know what tools are used for. And lo and behold, we saw many patients. So we showed a partially hammer and nail, and we showed a picture of a hammer, a screwdriver, a hacksaw, a chisel, and asked them to point to it. And some people didn't know which one to point. They didn't know that nails and hammers work together. But that was very unusual. Most people were able to point to the hammer. So what we did then next is we showed them another picture where there was a wrench, a screwdriver, a hacksaw, and a chisel. And we said, look, you can't find the hammer in your tool chest. Which one would you use now? And normal people pick up the wrench because it's long, it's hard, and you can pound the nails with it. But patients with dementia, different forms of dementia, stroke, and many other disorders, okay, didn't know what to do. And then we started talking to families of patients with things like Alzheimer's disease and asked them about those people's mechanical knowledge. How well could they fix things? What happened? And it turns out that this is a very common disorder. Knowing which tool to use means you have knowledge, okay, about what a tool possesses that will help. As I said, it has to be hard, rigid, long, to be used like a hammer. And this mechanical knowledge goes all the way through. So people who have loss of mechanical knowledge, okay, at one time they could be actually geniuses in fixing things. And the amazing thing from a developmental point of view, when I grew up, I knew several of my friends who had trouble reading, had trouble in math, but they could fix anything. And I also had friends who were the exact opposite, okay? They could actually read well, they could do math well, but when the chain came off the bike, they had no idea of how to fix it. So once again, you have to be aware, if you're a caregiver or a family member, about people's mechanical knowledge so that they don't hurt themselves and so they don't try and fix and hurt things that they're trying to fix. So these disorders, just in summary, are very common. They're common with Alzheimer's disease, they're common with vascular dementia, they're common with a whole bunch of other degenerative diseases and strokes. And family members should be aware of these disorders and help these patients as much as they can. So I'll stop there and leave another 5 minutes for questions. Again, thank you so much for inviting Ms. Coachman, for inviting me. And if people have other questions they have that can't be answered now, please let them go ahead and write to me, and I'll be happy to help anybody I can. So pleasure meeting you, and thanks again for inviting me.
Yes, thank you so much for that interesting presentation, Dr. Howman. We do have some pre-submitted questions, and as always, if you have any questions in the audience, if you have any specific questions, please feel free to type them in the Q&A and the chat function, and then we'll be happy to answer them for you.
Could you read the questions?
Okay, sure. Our first question says, do we know the cause of apraxia? So is it always associated with dementia?
It can be developmental. Many children have these disorders, as you know, okay? As I said, once again, people usually don't test for it, okay? But many people have developmental disorders. And it is very common, okay, with many disorders of the brain. So almost anything that injures the brain will cause apraxia. It is very common with dementing disorders such as Alzheimer's disease and vascular dementia. But you can see with other degenerative diseases such as Parkinson's disease, even in people who are not demented, will have many of these disorders. So they're very, very, very common. Head trauma, you can see it also.
Right. Brain is so complex, right? And then the next question says, you went over many different types of apraxia. What is the most common type and its key signs?
Well, I can't answer that because we never did any studies about what is the most common. Every one of these are common. I would say that probably the least common is the conceptual apraxia. But the three other types, the limb kinetic, the ideomotor, and the ideational, are more common. Probably the most common one, if I had to guess, would probably be the limb kinetic, one where they lose the ability to make deft, independent finger movements.
Interesting. Okay, and the next question says, what can I do if I noticed these signs in my loved one? You mentioned the nickel test. So how often should one do the nickel test, and will therapies like OT, PT, will that help as well?
Well, yeah. Can I take the Fifth Amendment on this? I don't know how often we don't follow. I mean, I can't answer that because I'm a neurologist, they come to see me one time. I test them, but I think if you're worried about people and you see that they're having trouble using their fingers, sewing or whatever it is, or buttoning their shirt, okay, you don't even need to do the test. You've diagnosed it, okay? Now, I'd like to say, hey, that occupational therapist, because they would be the one most likely to do it, okay? It turns out, like anything else, there are occupational therapists that know about this and try and deal with it, and guess what? There are other ones who don't know much about this, okay? And the reason I mentioned this and decided to speak about the topic because, again, when people think about dementia, it's memory loss, okay? And it turns out that memory loss is disabling, okay? And then they know maybe, there's some language problems. And virtually no physicians, okay? Very few physicians even examine this, but the patient's families will tell you, these are devastating. This person can't get dressed, okay? This person can't cut their food, okay? And it's important to know about those things, okay? To be able to both rehabilitate it and to help them out so you improve their quality of life.
Absolutely. In our programs, we say, when in doubt, check it out. You have to know what you're
I agree.
dealing with.
I agree.
All right. I believe that's all the questions I see. Again, we thank you so much for your presentation today, Dr. Howman. It was very, very informative when it comes to skilled movements in apraxia. So thank you so much. And I believe we will get ready for the next speaker right now.
Thank you so much. And then even in the future, if there's anything I can help with, please let me know. It's been a joy. Take care.
Absolutely. Thank you.